Hi, this is Dr. Krishna Deepak, and welcome to another episode of Steth and Sip, short for Stethoscope and Sip. This is a podcast that we bring to you where we call upon one of the most important doctors who are practicing in India, young doctors preferably, and they share their clinical insights with us. And today we have a very important and very famous interventional cardiologist all the way from Vijayawada who has graced us with this occasion today, and that is Dr. VSR Bhupal. He is an interventional cardiologist par excellence at Capital Hospital in Vijayawada. So, before I request Dr. PSR Bhupal to give a small introduction, I have to share a few pointers. One thing is, a lot of our Indian population are at risk of cardiovascular diseases, and we see in our practice daily a lot of hypertensive cases, a lot of MI cases, and patients are not able to recognize the basic symptoms also. And I feel that this field, we need to create more awareness of it. Without further ado, I would request Dr. VSR Bhupal to introduce yourself, give a brief about yourself. What made you come into the field of cardiology?
Hello, I am Dr. VSR Bhupal. I am practicing cardiology in Capital Hospitals, Vijayawada. First of all, I would like to thank you for having me on this podcast. I have done MBBS from Siddhartha Medical College, Vijayawada, and I have finished MD and DM from Nizam's Institute of Medical Sciences. And what made me take up cardiology is basically I have seen many people in my neighborhood and some of my relatives succumbing to heart attacks. So that was one which moved me. One of my close relatives, he had a severe heart attack and he died while on the way to the hospital, and which moved me a lot. I thought heart attack is a pretty preventable disease if taken care of early. So that is why I thought of taking up cardiology so that I could prevent or at least treat heart attacks in a proper way and in the timely manner so that it can save lives. Saving a life in an emergency, that is the true, thing which for which we take up medicine, as you know.
Yes,
so that is why I wanted to save lives on an emergency basis. So that is why I was involved in cardiology and I took up cardiology.
Wonderful.
Yeah.
So, I'm really thankful for you to come down here and share your insights with us today. So, why our Indian population, do you feel, in your experience, I'm sure you have seen a lot of studies, a lot of meta-analysis, and in your own experience, why are Indian population at risk of this cardiovascular diseases or hypertension, even kidney failure, diabetics? What do you think is the root cause of all this problem?
One thing I feel is basically, not what I feel, basically the data says the South Asian population are at an increased risk of heart attacks compared to the West. And heart attacks, it is surprising to know that heart attacks occur a decade earlier. So if you see the prevalence and the incidence of heart attacks, the South Asian population and especially Indian population, the first heart attack occurs a decade earlier. Whereas in the West, the average first attack of heart failure occurs at around 60 years. And in India, the average heart attack age is about 50 years. So it occurs a decade earlier. So there are many factors that has led to this basically. And because of the dietary patterns have changed a lot recently, and the stress levels have increased abundantly due to rapid urbanization and due to change in habits. Previously, the dietary patterns were not that bad basically, and now due to increase in this fast food culture, increase in stress levels, increase in changing work patterns, because many of the people working in India have odd working hours. They sleep less. They are under immense stress. And they have night duties and all. If you look at software people and in some other professions, even we doctors, we work during odd hours. We have less sleep. We are under immense stress. So that is one thing which has led to increase in heart attacks of late. And the dietary patterns, you can see there is increased consumption of trans fat. Unlike earlier, they used to have home cooked meals, but nowadays eating out has become a norm. So that is why the increase in trans fat consumption, increase in fried food consumption, increase in urban diets like having pizzas, burgers, and all, it has increased. The intake of carbs has increased. And this all led to the increase in heart attacks of late.
I understand. It makes sense. This is something that we are seeing in and out. So, are there any new guidelines for the hypertension? What is the cutoff limit that systolic or diastolic for starting antihypertensive therapy? Is there any specific guidelines which have come recently, or are we still following the old joint?
JNC 8 is the most followed. JNC 9 guidelines have come up, but they were not. It was not taken up by everyone because there are many flaws in making these guidelines. So JNC 8 still is the guideline to follow.
Okay.
Basically, if a patient has a blood pressure above 140/90, you need to treat it aggressively.
Consecutive blood pressure, you have to ask them to come back.
Yes.
And you ask for first lifestyle modification.
Yes.
Before starting this. And it's still diuretic first, or you start with?
No, basically any treatment for that matter, it starts with lifestyle modification. So be it diabetes, be it hypertension, or be it any other obesity, and because anything in medicine, it starts with lifestyle modification. Any preventable disease, prevention is always better than cure. So it starts with lifestyle modification. Then we begin drug therapy. If lifestyle modification doesn't work, then you need to go for antihypertensive medication. There are many medications available right now. Most commonly used drugs are, as we know, ACE inhibitors, ARBs, calcium channel blockers, beta blockers, diuretics, and mineralocorticoid receptor antagonists. These are all the drugs which we commonly use for treating hypertension. And most commonly, the initial drugs of choice, especially previously we used to start medication only single therapy. We used to begin with a single therapy, then increase the dose of the medication and wait, and then we used to add other therapies so to control hypertension. But the new guidelines, new data suggests beginning on a combination therapy. You need to start the patients on combination therapy, preferably either 2 or 3 drugs in combination, which brings down the hypertension in a better way, and the compliance also is better if you start them on a combination pill, because nowadays even 2 drugs, 3 drugs, there are combination pills available. If you start them as a combination pill, so the compliance improves, and you can bring down the hypertension in a better way.
Wonderful. So ACE inhibitors, we all know that cough is one of the major side effects with it. So which has shifted the focus to ARBs. And the drug or the molecule of the town is telmisartan. But I used to see olmesartan at a lower dose having better blood pressure control than telmisartan. So what do you think? Do you prefer olmesartan or telmisartan, or?
Both are good drugs actually.
But why do you think one is getting a lot of?
Could be due to marketing and all, but both are equally good. Specifically saying, there is no head-to-head trial comparing olmesartan and telmisartan. There are other trials. Each trial showed both ARBs to be good antihypertensives, and the most commonly prescribed drug is telmisartan, and olmesartan is also a good drug. Both have 24-hour action, and both have maintain a 24-hour antihypertensive effect when given. The advantage of these drugs is single pill a day is most commonly prescribed, but sometimes if they have an action of about 20 hours a day, there is a 4 hours of gap, even though you give olmesartan or telmisartan, to have an overlap effect for the 4 hours which we miss. Sometimes in resistant hypertensions, you can use it as a BD dose, but majority of times you use it as an OD dose, once daily dose.
Good enough.
Both are good drugs. There is no specific advantage of olmesartan or telmisartan over olmesartan.
In fact, when I practice, there are certain cases I even use losartan. If there
Yes.
is hyperuricemia is there,
Yes.
uric acid levels are high, then I have to pivot to losartan. So there, we have to, as doctors, we have to take into all clinical considerations before we prescribe antihypertensive. True. How commonly do you see renal artery stenosis? Because that is something that I have not seen doctors evaluate, and as soon as a young hypertensive comes, they straight away write
Antihypertensive
antihypertensives,
medication.
and that is one important cause, according to me, that has to be evaluated. So, how commonly do you see this problem?
Renal artery stenosis is not that common, but you need to have suspicion when you see a patient under 40. I mean, if you see a patient with hypertension who has resistant hypertension, and if he is young, less than 40 years of age, you need to consider all possibilities of secondary hypertension.
True.
There is something called primary hypertension, that is essential hypertension, for which there is no other cause except for hypertension itself. And there is secondary hypertension where there are various causes like hormonal causes like Cushing syndrome,
Yes.
hyperaldosteronism, and all. Then there are causes like renal artery stenosis, and these are all causes of secondary hypothyroidism and all. These are all causes of secondary hypertension. And you need to suspect renal artery stenosis, especially in young females.
Okay.
I mean, where fibromuscular dysplasia is one entity which specifically affects renal arteries. So, in such kind of patients, you need to have a clinical suspicion, and you need to get a clinical, Doppler of renal arteries to evaluate for renal artery stenosis. And other age group is especially elderly age group who have resistant hypertension, who have atherosclerosis, and atherosclerosis is one cause of renal artery stenosis. And you need to evaluate if you have a suspicion, if someone has atherosclerosis, coronary artery disease, resistant hypertension, you need to think of a possibility of renal artery stenosis. And some other patients, if they have flash pulmonary edema, recurrent episodes of pulmonary edema, recurrent episodes of hypertensive emergencies, in such kind of patients also you need to suspect renal artery stenosis.
Okay.
And diagnosing renal artery stenosis is not that difficult.
Yes.
Just by simple renal artery Doppler, which is done in about 10 to 15 minutes, you can diagnose renal artery stenosis. Once you diagnose renal artery stenosis, the whole therapy changes.
True.
You need to open the renal arteries. There are ways of doing stenting to renal arteries, ballooning renal arteries, and all.
There was also some RF ablation therapy also is available, less invasive. Good, excellent.
The newer therapies which we are talking is renal denervation therapy. That has come up, and the recent evidence, the Simplicity 3 trial, it has shown that in resistant hypertension patients, this renal denervation is an option.
Yes.
Yeah.
Even with, I have seen some very enthusiastic researchers saying that even for essential hypertension, we can do this.
Yes.
So I have my doubts on that, but what are your takes on that? Even for essential,
Especially, it can be offered in some patients if they are reluctant to take medication for hypertension control. So, if someone wants to be off therapy completely, so this can be tried, but it is not 100% successful. It works, but there is about 8 to 10% of resistance. Even though you do renal denervation, the patient still might need to take 1 or 2 pills. But it is approved right now in only resistant hypertensive patients, resistant essential hypertensive patients.
Excellent.
Secondary hypertension, again, it is of doubtful value, though you can do renal denervation, but it is not that effective. Even though you do proper renal denervation, still you might need to take 1 or 2 antihypertensives for your hypertension control.
Okay. Coming to the next group of drug, beta blockers. What is your criteria for writing beta blockers as a first-line therapy? What do you...
Beta blockers...
Metoprolol
especially, previously beta blockers were one of the first drugs that were used for hypertension control. As you know, still you see people using atenolol. Atenolol for hypertension control. It is the most prescribed drug actually, especially in rural areas and all. And it is freely available. So, for hypertension control, Metoprolol, there are studies that metoprolol, though it lowers blood pressure, it doesn't reduce the central aortic pressure.
Yes, true.
So, though it reduces blood pressure, it does not translate into clinical benefits. That is why beta blockers have come down the ladder, but still beta blockers are a good drug to use. Now, as I said, because antihypertensives are not used as a single therapy right now, it needs to be used as a combination therapy. So, you can combine beta blockers with any other ARB or calcium channel blocker. You can combine and give it. And that helps. It has an additive effect. It reduces the sympathomimetic activity and reduces the heart rate.
True.
That has its own benefit. So that is why beta blockers definitely in young hypertensives who have high sympathetic drive, especially in having high heart rates, tachycardia. In such kind of patients, you can use beta blocker in combination with ARBs. So my choice of treating patients, young hypertensives, is initiate a beta blocker in combination with ARB.
Wonderful.
That is my first choice.
Wonderful. Another compound that I am very curious about is diltiazem. So, what is your criteria for starting patient on diltiazem?
Diltiazem is a non-dihydropyridine calcium channel blocker.
Yes.
Yeah, it predominantly.
A lot of cardiologists prescribing it.
Yeah.
So, what is the added advantage it brings to the table, and what conditions do you usually prefer?
Diltiazem right now for treating hypertension is very rarely used.
Yes, it's
because it is a non-dihydropyridine calcium channel blocker. It is used more to control heart rate rather than controlling hypertension. It is used in some scenarios, some arrhythmias, especially in atrial fibrillation and in patients with supraventricular tachycardia. In such scenarios, diltiazem can be used to get down the heart rate rather than an antihypertensive. It is not, I mean, even by guidelines, diltiazem is not recommended as an antihypertensive therapy. For calcium channel blockers, dihydropyridine calcium channel blockers like amlodipine is recommended, and there are azilnidipine, amlodipine, cilnidipine. These are the drugs which are used as antihypertensive.
What I have seen is as an hypertensive add-on therapy, I have seen diltiazem being used. So that complicates my job. Once the blood pressure doesn't control, and if I want to give something like an amlodipine, this complicates my job. So you rightly said that it is not the first line therapy. Another compound of interest is sacubitril.
Yes.
When I was doing my MD, it was launched in India with combination azasaltan, I think, and Vimeda is the brand name. Vimeda. I'm sorry, I don't write that. So it's a cardiologist forte. What is the mortality benefit it is giving for CV mortality benefit? How much is it giving? And when they were promoting this molecule, and I have attended a lot of Western speakers on this, they say it is better than even intraventricular assist devices. So what is your take on that?
Basically, ARNIs are not used as an antihypertensive.
Not antihypertensive.
They are used in heart failure patients. ARNIs, this sacubitril.
Now we are into heart failure.
Yeah. So sacubitril and valsartan, it is a drug which is used in heart failure.
True.
The Paradigm HF trial was the landmark trial which has led to the utility of ARNIs in heart failure patients. Definitely, ARNIs have been, a blockbuster drug, if I can say that, in the last decade. So it has reduced the mortality of heart failure and morbidity to almost 30%. There is no drug off late which has shown so much of mortality and morbidity benefit in heart failure especially. And later SGLT2 inhibitors have come up, and they also could reduce mortality to about 10% mortality. But ARNIs, the reduction in mortality was almost 30%. So these were revolutionary. It is a revolutionary, game-changing drug in heart failure patients.
In fact, I have a patient who is on this, and whenever he gets shortness of breath, he is also on Ditor Plus. So I just say stop Ditor Plus, start Lasix for 5 days, then go back to this. Then his symptoms get resolved.
Yes.
So it has,
So you
yes.
you see patients. I mean, before taking ARNIs and after starting ARNI, they have immense clinical improvement. They feel better. Their breathlessness comes down. They have immense clinical benefit, and they have sense of well-being and all. So definitely ARNIs are recommended. Every heart failure patient, if there is no contraindication for starting an ARNI, needs to be on an ARNI.
Wonderful.
Yeah.
Excellent. So, coming to, let us shift gears again. Coming to a little different topic.
Yeah.
I feel that BLS needs to be taught in schools.
Yes.
And children, I mean, not exactly primary children, at least for higher grades, they should be taught about BLS. And all places which are public places, or even the studio, should definitely have an automatic
AED.
AEDs. It should have external defibrillator. It should have. What are your takes on this?
Yes, definitely that is a good thing which you have brought up. BLS is essential, especially in today's world where the awareness has improved. I
And
mean,
we are seeing in gyms,
yeah,
left, right, and center, people are
in
dying.
gym and all in you keep seeing videos on social media that someone is lifting weight and he suddenly collapses. Someone playing football or badminton or cricket or something, he will be engaging in a sport activity and he suddenly collapses, and you keep seeing people around who are caught unaware and
Taking
of the
videos.
situation, and they don't know what to do. I
They
mean,
keep taking
yeah,
videos.
they keep just some people, they try something on him, they do some chest thumping and all, but it is not in a proper way which needs to be done. So in such scenarios we keep seeing, and some people, they are busy taking videos and all.
Videos and all.
Some people call ambulance and all, but the precious time, you
Is
mean,
lost.
is lost. So if more and more people are trained in BLS, so you can give that first immediate first aid and all, and you can try to revive the patient. I don't say you can revive everyone 100%, but at least you can make a try, and you
If it
can,
was a VT or something like that, it would revert.
yeah. And if you have that awareness, only you can, if there is an asystole, you can do you can give artificial respirations, and you can do CPR. So it needs to be inculcated in the curriculum. So basically, at least in from 7th 8th grade probably,
Yes.
you can train children. You can make it a mandatory part in the curriculum, in their science
And all
textbooks and
offices,
offices.
gyms. I think
Having AEDs in public places, especially bus stops and in main centers of the
shopping
roads,
centers, airports, I
shopping
have
malls.
seen.
Yes,
In
yes.
our airport, I have seen it.
And you need to train people. You need to put a display on how to use it,
Yes.
because though AED is there, if people are not trained to use it, so it is of no use. So you need to have some display or educational video running over it, how to use
How
it
to use it.
in case of an emergency.
That's actually a very good thought. I think the government should take steps
Yes,
in this
yes,
aspect,
yes.
and I think it should be an
At least
important part
you
of.
can buy time, so that you can, if you, even if you get the rhythm temporarily, you will get time to shift him to an
To the
hospital,
hospital
so
and
that he
further
can be
stabilize the
taken
patient.
care of.
I think this is a very good suggestion from you that there should be also video running
Yeah.
that should help. And children, once it's like, we see a lot of rash drivers, and we blame the driving license,
Yes.
who has given this fellow license.
Yes, yes.
So why don't we train the younger generation so that they become more civic sense, like that? If younger generation in their biology, if they have this session, and a good amount of viva marks are given for successfully completing
Yes.
CPR, I think that would actually make changes.
Yeah, it should be a part, and it should not be only once. It should be reinforced,
Reinforced.
again and again. So it should be done in schools. Once you get into college, everything. It should be a continuous process. You need to reinforce it, and you should stress upon the importance of learning it.
Yes.
Especially you need not be doing BLS on someone else. Even if your family member or someone in your neighborhood,
Yes,
hey,
true.
if he has something, you will know what to do in such kind of situation till the ambulance arrives and they,
Arrives. True.
so it is very important, basic life saving skill.
It's a sad thing. Even in my medical college, I think we had one session of it.
Yes.
That's it. Not more than that. True. Coming to next part, which I was curious about, is interventions in cardiology. What are the new things which have come up? I know stents and everything; those are not very new now.
Yeah.
So, what are the new things that you people are doing in field of
Basically,
cardiology?
interventional cardiology has evolved leaps and bounds in the last decade. So even in there are, separate spectra in interventional cardiology. One is coronary interventions, which you said stents and all.
Yes.
One is structural heart disease interventions. Structural heart disease
Valves.
interventions is doing valves and all. So and electrophysiology. In
That's true.
electrophysiology, managing arrhythmias and all. So there are different diseases in cardiology which you need to treat, and every part is advancing like never before. So even coming to coronary interventions, if you see recently, the imaging has come up a lot, and there are in imaging you can precisely look at the plaque inside the coronary artery. You can assess the diameter of the coronary artery. Once you can it helps you in the need for any plaque modification tools like rotablation or IVL or laser, which has come up recently, and you can precisely know the anatomy of the plaque. You can decide the way of stenting you can do, and it has evolved a lot. So once the imaging has come up, the events have come down post stenting. In imaging, you can, with IVUS and OCT, you can precisely place a stent, and after stenting you can optimize the stent. You can look how well it got opposed to the coronary artery, how well it has expanded. So you can see is there any edge dissection, edge problem once stenting. You can give an outcome of near 100% even after stenting. Previously, once you stented, you would go by only eyeballing on the coronary angiogram. You see on coronary angiogram the stent is well expanded, the flow is good, and the procedure is over. But now with the help of IVUS and OCT, you can clearly see how the stent is behaving, how the stent has expanded and all. So the target lesion revascularizations, stent restenosis, stent thrombosis can be reduced a lot with the use of IVUS and OCT. Coming to coronary interventions, these are all the advances which have come up of late. And previously, though it was available, IVUS and OCT, it was not being used that frequently.
Very frequently.
But with now it is freely available in every cath lab almost. So it can be used to improve outcomes in coronary stenting. So these are the advances in coronary interventions which have seen of late. And in structural interventions, previously, if you have aortic stenosis or some mitral valve regurgitation, you need to go for surgery, open heart surgery. But of late, you have TAVR. There is transcatheter aortic valve replacement, and for mitral valve regurgitation, you have mitra clip. So with these two, the structural interventions have also, reformed a lot. Now you can do even patients with 80 years, 90 years, having severe aortic degenerative aortic valve stenosis. They can be treated with transcatheter aortic valve replacement, and they'll not have a single scar on their body, and mortality and risk has significantly come down, and they can just leave the hospital in 2 days. So absolutely low risk intervention. So if you and mitra clip as well in patients with functional MR and mitral valve prolapse and all. In such kind of patients, previously they need to undergo open heart mitral valve repair or replacement. But now with mitra clip, you can treat them, especially in functional MR patients with heart failure and all. Reducing mitral valve regurgitation with mitra clip brings down the morbidity and mortality a lot. So these are the advances which we are seeing of late, and the good thing is all these advances have already come to India, And even in India, in almost every center, they are doing good number of TAVR interventions of late. And electrophysiology also, management of arrhythmias have improved a lot over the last decade. And there are new 3D mapping and all have come up to target ablation precisely. And this is how interventional cardiology has evolved. So there is always scope for improvement. Probably we don't know in coming 10 years. It might evolve much more, and treating coronary artery disease or structural heart disease will be even more easier, and will be even more effective probably. We don't know how science grows over a period.
True, because when I was doing my MD and MBBS, getting into LAD territory, especially with left dominant system, it was straight away bypass.
Yes.
With I think I was the
Yes.
confidence was there to okay fine go into
Yes.
the system and get a stent done.
Previously, even in left main disease was default bypass. Now, even with IVUS and OCT, left main interventions have become very easy, and with good outcomes. So this is how interventions have evolved, and now even in OCT, AI has come up, artificial intelligence. So in OCT, you can see what is the length of the stent needed. The AI gives a calculation. It only assesses the plaque and it guides you how to intervene.
Okay.
What is the size of the balloon you need to take? What is the size of the diameter of the stent you need to take? What is the length of the stent? Precisely, it calculates and gives you a number.
Wonderful.
So it guides the interventionalist much more, and outcomes improve a lot.
True. That is true. But still, I think CT surgery, there are some cases that still we have to
Yeah.
use CT surgery. Especially recently, I've seen a case where we required the aortic valve procedure, but that was quite expensive. So they were not affordable. They had to go with minimally invasive procedure.
Yes.
So cost is one thing that does come up.
No, basically, cardiac surgeon and interventional cardiologist, they need to be friends and they need to work as a team. So there are no, I mean, for every patient, you need to have a heart team approach. Basically, they need to work in tandem. And if there is a problem during an intervention, cardiac surgery is the one who comes to your rescue and who helps getting the patient out of trouble. So definitely it is a teamwork basically. See, just like a cricket team, you need a bowler and a batsman to win a match. So even in this, if you want to give a good outcome to the patient, both cardiac surgeon and cardiologist, they need to work as a team to give better patient outcomes.
True. So let's shift gears a little bit. And what do you think that a common man, especially a person, do you think after crossing 30 or 35, do they have to get a full cardiac workup, especially if they have risk factors and if they have a family history? And if so, yes. So what are the investigations of your choice?
Now a lot of investigations have come up, and definitely after age of 35, you need to get yourself checked periodically. Because the incidence of heart attacks, as I said, it has increased a lot for various reasons, especially in India. And at the age of 35, at least, you need to know your numbers right. You need to know how much your cholesterol is, how much your LDL, how much your triglycerides, and basic blood panel. I mean, like total cholesterol and LDL levels, triglyceride levels, basic lipid panel, and basic creatinine and all. Basic, you need to know your basic health, how and these are the basic parameters which helps you. I mean, you should know your fasting sugar levels, you should know your HbA1c levels, and you should know your weight, your BMI and all. You should, these are the basic numbers which you need to know, which anyone needs to know. And especially if you are at a higher risk of having heart attack, basically if you are obese, if you have a strong family history, if you smoke, or if you are a diabetic or a hypertensive, you need to go the extra. I mean, you need to put in extra effort to assess if you have a risk of having a heart attack in the future. So, if you have a higher risk, you need to do a TMT. Treadmill test helps you in knowing any inducible ischemia. If there is any lesion causing ischemia, it can be brought out on treadmill. And one of the best tests which I would recommend a patient, any person above 35 to know if he has any risk of heart disease is CT calcium score. CT coronary calcium score is one of the best tests available right now. In a span of 5 minutes, you can get a test done. You need to know your, just like knowing your numbers, which I said, your lipids and all. Every person above 35, he needs to know his CT coronary calcium score.
And nowadays it's part of the packages also, which
Yes.
many of the diagnostics are giving.
Yes.
One thing that interests me is previously it was reduction of LDL, LDL, LDL. Now the thing is not only reduction of LDL but increasing HDL. And in 1980s, 1990s, and maybe early 2000s also, niacin was
Yes.
very much in, but niacin had its own problems. Then now we are getting into saroglitazar. So how important is this glitazar group of drugs in your practice? Do you prescribe it a lot? And show us a little light on this aspect.
Saroglitazar, it is used in, it is not approved in cardiology basically. And saroglitazar, it is used in fatty liver patients more of. Not in cardiology. It did not show any benefit in reducing cardiovascular mortality. There is no data or evidence showing that saroglitazar would reduce cardiovascular mortality or cardiovascular morbidity. So one thing I would say is, reducing cholesterol is one aspect. And one more important thing which we need to know is not only numbers, you need to know the level of inflammation in the body. That is one thing which causes heart attacks. Though you keep seeing patients who have absolutely normal cholesterol levels having heart attacks. So cholesterol is not the only thing. Even though you have high cholesterol, you need to know the level of inflammation, because ultimately the vulnerability of the plaque is what causes it to rupture and cause a heart attack. So for the vulnerability or for it to rupture, there is high inflammation in the body, it can cause plaque rupture. So inflammation, how do you know inflammation in the body? One test is HSCRP. HSCRP, getting a HSCRP done lets you know how much inflammation is there in the body, and it acts as an additive test along with cholesterol levels to assess the risk and of having a heart attack. And one more other thing which has come up is lipoprotein A.
Okay.
Lipoprotein A is another genetic risk marker to know whether you have a predisposition to have a heart attack. It is genetically determined. It cannot be modified based on your diet or anything. If you have a strong family history of heart disease, you can get your lipoprotein A checked. If it is greater than 50, the level is greater than 50, you have a higher risk of having a heart attack. And if your lipoprotein A is greater than 50, you can start using aspirin and you can go more aggressive in your lipid control and your lifestyle management. That is one test which can be used to detect your risk of having a heart disease. And as I said, CT calcium score is one test which is freely available. And I would say that every patient, I will not call a patient, or every person above 35, he needs to get his CT calcium score done.
Wonderful. So before we end session, something I feel personally very important is DVT. As soon as nowadays you go to a hospital, first thing they put is an IV line.
Yes.
They secure, you go to an emergency, even before they ask you your symptoms, they secure an IV line.
Yes.
And PAN and Zofar go hand in hand.
Yes.
I feel that in similar aggressive way, you should also start DVT prophylaxis. Because especially for patients with continuous stay of hospital, I think you should assess the DVT risk and you should start DVT prophylaxis. How in agreement are you with this? And the second thing is, what is your go-to medication for DVT prophylaxis, injectable and oral?
For DVT prophylaxis, especially comes in long-standing bedridden patients and patients with malignancies. These are at higher risk
This
of
is
having
established risk
a
factors.
DVT. And every patient in ICU, if there is no contraindication, he needs to be on DVT prophylaxis. Especially patients undergoing orthopedic procedures for long bone fractures and all, hip replacement and all. They are bedridden for long durations. So that is why they need to be on DVT prophylaxis. I would say low molecular weight heparin is good for DVT prophylaxis, once daily dose. So that suffices. Or if they feel it is expensive, then they can, even unfractionated heparin can also give you the same effect which a low molecular weight heparin gives, but it needs to be given twice a day. So these are the true drugs which can be used in hospital. And if the patient is discharged, you have DOACs now, direct oral anticoagulants like rivaroxaban and apixaban, dabigatran. And comparing these three, I feel apixaban is lot safer compared to rivaroxaban and dabigatran.
Dabigatran had a very bad case of bleeding.
Yes.
There is an antidote for that.
It is not freely available.
Freely available. It is Suzimab, if I'm not mistaken. But I had a very bad case, and the patient came into ER and he sat and suddenly passed out, and he had a big pile of blood coming from his anus. So it took me a lot of time to stabilize him. That is true. And Enoxaparin, I think it is quite cheap now. It has become cheap. Even apart from ortho cases, and I think that we should, even for other patients, we should aggressively look for risk factors. We have to see the score, DVT score, and I think we should start low molecular weight heparin, especially in hospitalized patients. So true. Thank you very much, sir, for sharing such great insights. You have increased my understanding and my appreciation for your specialty. And thank you very much for coming here, sir.
Yeah, thank you. My pleasure.